Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramm. Marcus at Home welcomes Professor Adrian Martineau in London, UK, and Dr. Arne Soraas in Oslo, Norway, with whom we would like to discuss the role of vitamin D supplementation for preventing COVID-19, based upon their large randomized controlled trials, CORONA-VIT in the UK and CLOC in Norway, which have been published back-to-back 3 weeks ago in the British Medical Journal. Adrian, Arne, it's a pleasure and an honor for us to host the two of you tonight. Thanks for being our guest. Adrian Martineau is Professor of Respiratory Infection and Immunity at Queen Mary University of London. He's Chief Investigator of the COVIDENCE UK study, in which the randomized CORONA-VIT study was embedded. COVIDENCE UK aims to understand risk factors for coronavirus disease among UK adults. And even before the pandemic, one major focus of Professor Martineau's research work were the clinical and immunological effects of vitamin D in respiratory diseases, particularly in tuberculosis, where he conducted a large phase 3 intervention trial published in the New England Journal 2 years ago. Arne Soraas is MD and PhD. He works as a researcher in the Department of Molecular Microbiology of Oslo University Hospital. He's a specialist in infectious diseases and is chief investigator in the Norwegian Corona Cohort, which follows 200,000 Norwegians throughout the pandemic. The CLOC study is embedded in this cohort. Now, both COVIDENCE and CLOC analyzed in the general population whether vitamin D supplementation actually protects against COVID-19. The two studies have each a unique design so that their results should be considered to provide complementary rather than overlapping information. My co-moderator today is Professor Martina Sester from Saarland University in Homburg, who leads the Department of Transplant and Infectious Immunology and who has published seminal studies on the immune responses in COVID-19 vaccination. My name is Gunnar Heine. I'm a nephrologist from Frankfurt, Germany. So before switching the microphone to Martina, I would like to ask a single background question on the evidence for vitamin D supplementation in infectious disease prevention that had been gathered before the pandemic. Martina will discuss the immunological effects in more detail later. So Adrian, you have published 2 seminal review articles of randomized controlled trials that tested vitamin D for preventing respiratory infections, mainly from the pre-pandemic era. These were published in the British Medical Journal and Lancet Diabetes Endocrinology.
Thank you, Gunnar. So before I turn to those, I'll just provide a little bit of background in terms of why we did the meta-analyses in the first place, based partly on what we knew about the immunomodulatory effects of vitamin D, specifically upregulating innate immune responses to viral infection and downregulating potentially harmful inflammation. And secondly, a large body of observational epidemiological data reporting independent associations between low vitamin D status and increased risk of acute respiratory infection. So this combination of observational epidemiology and laboratory findings then led us to do some primary RCTs and many other investigators. And as you say, we did 2 meta-analyses. The first published BMJ 2017 was an IPD or individual participant data meta-analysis of about 11,000 participants in 25 RCTs. And then the second one, published more recently in Lancet Diabetes, was updated to include data from nearly 50,000 participants in 43 RCTs. And the second one was an aggregate data meta-analysis, albeit stratified. The findings contrasted slightly in detail, but the headline finding from the 2 meta-analyses was similar, in that overall we saw a pretty small but statistically significant protective effect of vitamin D supplementation in reducing risk of all-cause acute respiratory infection. And this is, as you say, Gunnar, all in the pre-COVID-19 era. The meta-analyses differed in that the first of them showed heightened degree of protection in people who had lower baseline vitamin D status, whereas that finding wasn't replicated in the second of those meta-analyses.
So thank you. This was, I guess, the starting point for many other studies that have been carried out, and of course the two that we are discussing today. So we start off with the CLOC study from Norway, and Arne, we would like to briefly hear the description of the study design. Yeah, maybe we start off with that.
Yeah, the study design is really simple. This was a randomized study, blinded, and we divided the people into cod liver oil, which is a Norwegian vitamin D supplement, also containing some omega-3 fatty acids, traditionally used for many, many years, probably since the Vikings or something. So, and the other got corn oil with the same flavor, without vitamin D, of course. So the simplest design possible, we gave people who didn't know what they got a bottle of either of those two, and then we observed them over half a year, and the endpoints were COVID infection, of course, and also primary endpoints in respiratory tract infections.
Okay, and which were the major findings then?
Yeah, the major findings were negative. So we knew at the beginning that the COVID endpoint could be difficult to reach, because this was planned in the summer of 2020. So nobody knew how common COVID would become. And when we said we assume 1% in the study population during the winter, people were almost laughing and said that's unrealistically high. We thought, yeah, maybe 1% is okay. It ended at 1.3, so we were happy about that. We focused on COVID, but we knew that this study would also be able to answer some questions about other respiratory tract infections, because we assumed those would be much, much more common than COVID. So we included those as primary endpoints in the study. So we had 4 co-primary endpoints. 2 regarding COVID and 2 regarding respiratory tract infections. And of course, as is expected, those respiratory tract infections became very, very common. So we had a very good strength on that endpoints. And the results is completely null results. There were no protective effect against COVID. We didn't find anything about the other respiratory tract infections either. So it's very extremely close to 0. So disappointing, of course, but yeah.
Yeah, that's indeed disappointing. So if before we go maybe a bit closer into the data, I was just wondering why you chose the cod liver oil. I mean, you said it had some sort of tradition in Norway, because I guess if you set up such a study in Germany, I doubt that we could recruit 17,000 in one arm. So that's quite amazing. So why did you choose that? And could you specify again on compare it to just the capsule, for example, or why did you just chose this one?
Yeah, we could have used capsules, but this was, we were in a hurry because we wanted to start the study before the winter. We didn't have any financing, so needless to say, the sponsor was a cod liver oil producer, but they also produce the capsules. But that had to be with the practicalities. So this cod liver oil is actually produced here in Oslo, and so it was easier to get that to work fast. And we thought it was, most Norwegians know cod liver oil, and very many used it when they were kids. It's supposed to have a very strong taste. People are skeptical about it because of that, but modern cod liver oil is very, very different. So surprisingly, people didn't guess what they got. Most people thought they got placebo, actually.
I noticed that it was more than, I don't know, 78% around that. So it cannot taste that disgusting. I guess you flavored it with lemon, I read, yeah.
Yeah, we did. So it's very difficult to taste the difference, but it was practical issues, actually. So when we had this idea, and And it has to be said that, you know, we probably can't go into the background of the study, but of course, Adrian's papers were one of the backgrounds important that made us do this study. One, we looked at our own data and also saw that cod liver oil users did get less COVID than other people. So we had a reason for actually choosing the cod liver oil, but yeah.
Okay. So one thing which was noticeable was the fact that at baseline, most of the people in Norway, apparently, and we can just discuss this in relation to what Adrian finds in UK, were not actually vitamin D deficient. So if I recall the figure, more than 86% or 86% had more than 50, so they were not deficient. So how come this is the case, or could that be basically a finding this which dilutes a potential effect because most were not actually deficient?
Yeah, I think definitely the finding has the potential to dilute an effect, but it won't dilute an effect on respiratory tract infections because we had so because we had so many of those in the study. So, but for COVID, that could have an effect. And I strongly believe that if you are deficient in vitamin D, you really need it. So I think that's no discussion anywhere. So, but maybe a little bit surprising that so many were not deficient, but this was in the start of the winter, late in the autumn. Also, I think you can presume that the people in such a study will, you know, think more about their health than the average population probably. So
yeah, and this fact, is it due to the fact that I don't know, nutritional differences? So like, do they eat more fatty fish or things like that?
The Norwegians, or?
Yeah, certainly, yeah.
Yeah. I don't know. It is a problem with the vitamin D deficiency in Norway, so that's a known issue, particularly of course in immigrant populations. But vitamin D supplementation is a thing in Norway. So, but in the study population, the deficiency rate wasn't that high.
Okay. Yeah. Thank you.
Maybe I can just add the question, do you have foods that are supplemented by vitamin D in Norway like the US American do? So,
much less, I think.
Yeah.
There are some foods, but I think it's like butter, it was some milk, but it's not much food supplementation.
So not like the US American way of fortifying actually everything with vitamin D. So it's rather like the continental European way. Yeah. Yeah. Okay, so then let's switch to the UK study, which has a design that is, from a clinical point of view, very interesting, because before supplementing, you did test for vitamin D levels. But we would surely be happy to hear the design from you, Adrian, because you did the study.
Yeah. Thank you, Gunnar. And congratulations to Arne for a fantastic trial. I think to do a placebo-controlled RCT on that scale is, you know, it's a super robust study. So well done.
Thank you.
Our study contrasted somewhat in design, in that we had issues around regulatory approval of a placebo-controlled trial, and so we had to be a bit more creative in designing the study, and we came up with the idea of, instead of evaluating vitamin D against placebo in a pure scientific efficacy study, we ended up evaluating a pragmatic intervention to boost vitamin D levels in the public. So this intervention, rather than offering someone a placebo or a pill, the intervention was offering someone a test of their vitamin D status. And if they then accepted that test and it showed that they had a 25 hydroxy D level less than 75 nanomole per liter or 30 nanogram per mil, we then supplied them with a free supplement of vitamin D at 1 of 2 doses over a 6-month period. So I think it's really important to interpret our results in the light of the nature of our intervention. So while Arne's study is a pure scientific study addressing the question of efficacy of vitamin D, ours is a pragmatic trial which assesses the efficacy of a public health intervention to boost vitamin D levels. And they're subtly different things. That said, our population did have lower baseline 25-hydroxy-D levels in general than the Norwegian population. Not a surprise, really. You know, rickets is always called the English disease, and we don't have a tradition of eating much in the way of oily fish. There's not much sunshine around in December. So we did see quite a high prevalence of baseline deficiency. And the supplements we gave tended to have a higher amount of vitamin D than cod liver oil. So the low dose one was 800 units, which are around about twice the dose of the cod liver oil tablets. And the high dose we gave was 3,200 units. So around about 8 times that dose. So I think there are important similarities and contrasts between the 2 trials. And I think what you said is absolutely right, that we're not asking the same question, but we're getting the same answer, which is essentially that our intervention had no impact either on all-cause acute respiratory infection or on incidence of COVID-19 specifically at either of the doses investigated.
And interestingly, your primary endpoint was not fully focused upon COVID-19, but your primary endpoint was any kind of respiratory disease.
No, it was acute respiratory infection specifically.
Yeah, sorry.
And this had to be confirmed either by a doctor or by the result of a laboratory test. So it wasn't a symptom-based definition, but it was all-cause acute respiratory infection. And this was really driven by, first of all, the meta-analyses, because that was the primary outcome of our meta-analyses. And secondly, a factor which Arne also discussed, namely, when we set it up, we didn't know how much COVID-19 there would be. And we wanted the trial to have meaning, even if COVID-19 had miraculously disappeared. We still wanted the trial to have a readout. And so that's why we went for all-cause acute respiratory infection as primary, with COVID-19 specifically as a major secondary outcome.
What I find really fascinating in both studies is this very modern approach, so that you approach the patients who are not really patients, but they come from the general population via email. You don't see them regularly in a study center. It's virtually based upon electronic communication with your study participants. So that's very fascinating, particularly considered from a German point of view, where things like these are very difficult to do actually. But there's maybe a con side. So how sure are you about the quality of reporting? So do you expect really nearly complete reporting by this way to contact your participants via emails?
Arne, do you want to go first?
Yeah, I think we're actually a little bit proud of the electronic communication, and we had a really good help there to setting up the Norwegian Corona Cohort, as you presented in the beginning, from the University of Oslo, who has this system with the electronic signatures, meaning that we can include people just by they going to our webpage, they sign, with the 1 or 2 factor authentication, so we know who they are, and then they're signed into the cohort, and also, later the cod liver oil study. So we're actually proud of it, and it makes things possible to do that weren't possible before, particularly regarding the number of patients, or participants. Of course, as you say, we need the responses from the participants, and we use a lot of energy in contacting them by email and SMS, actually, text messaging during the study period. But in Norway, we have, and probably also in the UK, we have a very good infectious disease registry. So all cases of COVID were reported, and we also used these negative tests as one of our endpoints. So a negative COVID test were not always, but the large majority was caused by respiratory symptoms. So they had symptoms, they tested themselves, it wasn't COVID, but that was one of our endpoints actually. And these registries, they have, close to 100% or 100% coverage. So we had two endpoints. One was the self-reported respiratory tract infections, and then the other one was the registry based. So there was a difference, not in the results, but in the numbers. And of course, the registry based were the best, or the highest number at least. So yeah, but I think it's a strength with the existence of these registries, as long as they have a good coverage. They don't know now, they don't have any coverage anymore, but during the pandemic, they really had a good coverage.
Yeah, and for the UK, it was essentially a similar approach. So we had the questionnaires and they were pretty well completed, and then we complemented them with routinely collected data. So I think the two approaches are pretty much the same.
Second issue, which I found very interesting, that you included only individuals who had no vitamin D supplementation before the study started. Then during the study, about 50% of those who were actually not randomized to the intervention started supplementation on their own, which in my personal view reflects this uncertainty in the population, that many people really turned to some ideas of protecting them by something which has not been evidence-based. But if I got it right again, then these 50% do not really substantially affect the results, because you still had a good increase in vitamin D in those randomized to intervention.
Yes, so we were aware that, particularly because ours was an open label trial, again in contrast to Arne's, that the people in the control arm would know they weren't taking vitamin D. And so because they might believe in it, they might start to take it. So we asked everybody every month about their intake. And you're right to say that half were classified as taking vitamin D on at least one occasion, but some of those were people who said they just took one pill during the 6 months. So these aren't regular users, but we wanted to make it very, very clean, the sensitivity analysis. So what we did at the end of the study was we anticipated this problem, and we pre-specified in the protocol a sensitivity analysis which excluded anybody who said they took a supplement at any point from in the control arm. We also excluded people from the intervention arm who said they didn't take supplements. This was a very small number. And the fact that this sensitivity analysis yielded the same finding overall as the main intention to treat analysis, it kind of increased our confidence in the validity of the main finding.
One reassuring effect seen in both studies was that the number of adverse effects was very low. So we had a couple of patients coming in here in the last 2 years in the Department of Nephrology with vitamin D intoxication, but apparently neither in Norway nor in the UK this was a real issue. The number of adverse effects was very low.
This is an oil, so you get this large bottle. So you're gonna work really hard if you're gonna be intoxicated.
It's a good argument anyway. Really yeah.
So that's a tough one to get intoxicated by cod liver oil. But that's also a safety feature of the study, maybe, that we were quite sure people wouldn't get too much. So.
Yeah, I mean, interestingly, in the UK, the only person who developed hypervitaminosis D was actually somebody in the control arm who was self-supplementing. But in general, you have to take large bolus doses or very large doses consistently to get hypervitaminosis D. I mean, people do it, but I think that because people were taking part in our trial, they were tended to take our advice to take the medication as prescribed.
So what we see here from time to time are people who are prescribed 20,000 units per week and who take this once a day, and they come back after 4 weeks or so, and then they really are at risk of substantial hypercalcemia. But surely that's not the prescription by the doctors, but the way the patients or individuals take the pills then. So one last question before switching the mic back then to Martina. Both studies were initiated few weeks or months before vaccination became available, both in Norway and in UK. So in how far did the initiation of vaccination affect your study results?
Well, I'm glad you raised that, Gunnar, because I think it's really important when we interpret the findings of both these studies. They were done actually very similar time periods, and the rollout of vaccination, I think, was quite similar between the two countries. Obviously, they were highly effective particularly in reducing disease severity, but also incidence. And so there was potential, particularly for our study, which was smaller, to introduce type 2 error, reduce our power. But I think also, importantly, there's potential to mask an effect of vitamin D. And although it's a small study, but there is one study out of Mexico, just done in around 320 healthcare workers in the pre-vaccination era, showing that vitamin D had a protective effect against incident COVID-19 in unvaccinated individuals. So there are some methodological questions around that study, but I think it is of at least anecdotal interest that they showed a protective effect, whereas we didn't. Although, final comment, we did stratify the analysis to look at the pre and post-vaccination experience, and we didn't see any difference in the effective allocation in a survival analysis restricted to pre-vaccination follow-up and post-vaccination follow-up.
So when looking at this Mexican data, they kind of look somewhat too good to be true in my view, because the effect is so large in this rather small study. So it's another very good reason to read the two studies from Norway and from UK, because they surely give more substantial evidence.
I think also regarding the vitamin D or the vaccination during the study, we in our supplement we have a Kaplan-Meier plot of those who received the vaccination during the study period and those who didn't. And if you are in doubt of the efficacy of vaccination against COVID, you should look at that plot, because that's really fantastic. It really shows in a completely independent study, just by self-reported vaccination, that it really impacts at that time who it's protected against getting COVID at all. So it's a good argument for vaccination if you're still unvaccinated.
Yeah, although it is a confounder here. Another confounder could also be the mask mandates that were in place during these times, which could have or which have naturally lowered the incidence of respiratory infection. So I wonder whether that was addressable at all. Or, yeah.
I don't think it should have acted as a confounder, because these are RCTs, so that should have been distributed equally between arms.
Okay.
I mean, my reading of the masks is that they protect the contacts of infected people rather more than the wearer themselves. I think one final comment on vaccination is that we actually did an immunology study nested within the trial in vaccinated individuals, looking at antibody and T-cell responses to investigate whether vitamin D might augment vaccine immunogenicity or protective efficacy. But we also saw no protective effect. That paper just came out this week.
Ah, that's interesting.
So it's no effect on the immune function or responsiveness to vaccine, unfortunately. I'm always trying to repurpose.
So that brings us to the immunological basis. So could you just briefly outline how vitamin D acts in terms of this effect that you observe?
Sure, Arne, do you want to go, or shall I?
I think you definitely should go here.
Okay. So yeah, broadly, vitamin D augments innate immune responses to a whole range of respiratory viruses. One of the most well-recognized mechanisms is via upregulation of antimicrobial peptides. many of which are cationic and which can actually disrupt membranes of respiratory pathogens. But also vitamin D can support a process called autophagy, which is essentially a sort of packaging process by which the cell can get rid of pathogenic material and control infection. It also supports the production of reactive oxygen and nitrogen intermediates, which are also toxic to pathogens. So that's one side of the coin. The other side of the coin is this effect on inflammation, which I think particularly attracted attention during COVID-19, because so much of the adverse effect of COVID-19 was mediated by dysregulated inflammation, not by the virus itself. And we'd shown in the context of TB that when we give high doses of vitamin D to our TB patients, we managed to downregulate a lot of the Th1 mediated inflammation. So interferon gamma was going down, IL-12, TNF, CRP, IL-6, all of these mediators were going down. And there are a few different pathways by which that's mediated. But I think the sort of take-home message is that there's a sort of yin and yang action of upregulating innate immune responses and then dampening down inflammation, which in theory should have made it a perfect design of vitamin.
Yeah, indeed. So, I mean, you mentioned your TB studies. So in that regard, I recall that there were some aspects or some ethnic groups, for example, Black ethnicity, or there are some genetic polymorphisms that predispose to a better or worse effect. So is that of any relevance to consider in future trials?
Yeah, so we didn't see an ethnic effect modification, but we did, in one of our TB studies, identify a polymorphism in the vitamin D receptor. So people who had the mutant allele were more vitamin D responsive than those who didn't in this polymorphism. Mm-hmm. I think that's of scientific interest. We actually tried to replicate that finding in a second RCT in Mongolia, and we didn't manage to replicate. But from a public health perspective, I think it's really of academic interest, because nobody's, vitamin D is very cheap, it's very safe. Nobody's going to genotype somebody before deciding whether or not to give them a supplement. So of potential scientific interest in that it might provide some mechanistic insights, but from a practical perspective, maybe less important.
Mm-hmm. Okay, thank you.
So before switching back to the clinical outlook, how to treat or not to treat our patients in winter 2022-23, I would have one final question on tuberculosis, because we have two experts on tuberculosis here. And 2024 sees the centennial of Thomas Mann's novel, That Zauberberg, the Magic Mountain, which still arises 100 years later, the image of mainly wealthy European patients affected by tuberculosis who gather in a sanatorium in Davos, Switzerland, apparently to have their tuberculosis cured by spending hours on sun terraces. So is this something from today's point of view which may have really affected health of the people 100 years ago, before there were antibiotic medications against tuberculosis? So in the hindsight, do we believe that this may have some effect upon these patients 100 years ago?
Well, anecdotally, possibly. There's further supporting evidence in that very high doses of vitamin D2, ergocalciferol, were administered orally, particularly to patients with cutaneous tuberculosis in the pre-antibiotic era. And if you see photographs of people before and after that, they're quite dramatic. You see quite a dramatic clearance. But the situation then was there was nothing else, and nobody evaluated in a randomized controlled trial. So we probably will never know. My hunch is that, particularly maybe for cutaneous tuberculosis, there was a real effect. But in the antibiotic era, obviously that effect is then masked by much more effective antimicrobial therapy. Although, as an interesting aside, when we look at modern era trials of adjunctive vitamin D to treat tuberculosis, there is a little bit of signal for MDR disease. So if again you have a situation where antimicrobial therapy is not as effective, then you perhaps start to get a signal from host-directed therapy coming through because it's not masked so well. So I think it's interesting. It's just a shame no RCTs were really ever done.
So let's look to the future. And us as clinicians, how should we proceed now in October 2022? So your trials suggest against routine supplementation, and they also suggest against population screening for vitamin D deficiency, which actually is fully in line with recommendations from many scientific societies. Are there people, subgroups of individuals, of patients maybe, where you would still recommend us to check, so in early autumn, vitamin D levels and check for vitamin D deficiency?
Adrian?
Yeah, so I think from the perspective of COVID prevention, we have to believe our findings and say that there's not currently a good evidence base to test and replace vitamin D for COVID prevention. But I think let's not throw the baby out with the bathwater. We know that vitamin D is really important for musculoskeletal health. You know, it's a key vitamin to support calcium absorption and bone mineralization. And in the UK, you know, we still see cases of rickets. We still see several hospitalizations with hypocalcemic seizures every year. We even see deaths from vitamin D deficiency cardiomyopathy. So profound vitamin D deficiency remains a public health problem in the UK. I suspect less so in Norway. And there's still a good reason to avoid profound deficiency, certainly from a musculoskeletal perspective. So the UK government actually advises everyone in the general population to take a supplement of 400 units, 10 micrograms per day during winter, spring. And it further advises people at high risk of deficiency, namely older adults who can't get outdoors, and people at high risk, in high risk ethnic groups, particularly of Black African, Afro-Caribbean, South Asian ethnicity, to consider taking a supplement all year round of 400 units, 10 micrograms. And that dose is predicated on what's required to elevate 25-hydroxy-D levels above 25 nanomole per liter or 10 nanogram per mil in 97.5% of the population. That's quite a low bar to achieve, a lot of people would say, but we're not even achieving that in the UK. So I would support that government advice from the perspective of protecting musculoskeletal health and particularly warding off some of the most extreme manifestations of deficiency.
So in Norway, the same recommendations, Arne?
Yeah, I think they are a little bit less, they're milder. It's not generally recommended. It's recommended for specific groups, pregnant, some ethnic groups, older. So it's possibly a little bit smaller problem in Norway actually, but we have recommendations on how much vitamin D you should consume, and our studies, fully supportive of just continuing those in Norway. So it's not that study. That's absolutely no reason to change the recommendations as they stand today.
I mean, Norway is interesting from 2 points of view. On the one hand, we always consider you to be very healthy in Norway and to do sports all day long. So, but on the other hand, surely you have regions in Norway where you don't see any sunshine between, say, November and February. So then I guess vitamin D supplementation would be of more interest than in Barcelona or Rome or something in Southern Europe.
Yeah, it depends on what you eat, of course. So, but if you eat varied Norwegian food, you should get what you need in vitamin D. But not everybody gets it, and I think a lot of Norwegians do take vitamin D supplement, either as cod liver oil or as just a supplement. So it's a very widely used supplement, particularly since it's so dark in some parts of the country. But I would say also here in Oslo, you don't produce any or very little vitamin D in the sun in the middle of winter. So it is very different from Germany and probably the UK. It's almost no ultraviolet light, and so we also use this sun or artificial sun for TB patients 100 years ago, and probably it has something for it. It's not physiological to, I would say it's not physiological to live in Norway during the winter. So it's much darker than the body is built for.
So maybe one last question from my side with the perspectives from a research point of view. So given the evidence of an effect in the meta-analysis and the lack of evidence now in these two trials, what are your perspectives to go from here now in terms of research? So would you do anything differently in a future trial, or do you have any ideas for future trials to go from here?
So maybe I can quickly comment on the meta-analysis. The pooled effect size that we saw in the updated analysis was a bit smaller than in the original one. And we lost signal for the high effect in people who were deficient. Also, the funnel plot, which for those of you who aren't 100% familiar with meta-analysis, is basically a device for looking for publication bias, did show a lot of asymmetry. Mm-hmm. And I'm definitely considering the possibility that at least some of this story may have arisen from publication bias, namely smaller trials with null or negative findings not getting published, and a selective publication of smaller positive trials. Mm-hmm. Now that the story is maturing, we're seeing large phase 3 RCTs coming out with null findings. I don't think vitamin D is it's not a magic bullet against acute respiratory infection, certainly if it does have an effect. So I think a pretty cautious interpretation of those findings is appropriate. With regard to future studies, I think we've basically made things very difficult for ourselves by doing big trials with null results. And the appetites from big funders in the context of these studies, but also studies in the US and us coming out of Australia and New Zealand's big phase 3 RCTs with null findings for a lot of the non-communicable disease outcomes. That's also tending to make funders a little bit less enthusiastic about supporting further vitamin D trials. And in fact, we had to get our study funded by industry because the UK government wouldn't support it. Mm-hmm. Arne, what are your thoughts?
Yeah, I think we have not been thinking a lot of the next study, but we have been thinking a lot what we're going to do with the data that we already have in this study. So it's a randomized study. We are going to screen the data material for other effects. That's not that's not going to be the same kind of study, but we will look for all kinds of other effects of the vitamin D. Also, did it have any effect in the next half year? So we're following these persons for up to 2 years with health registries and also self-report. So we're going to observe them and see if there are any differences, and that's both positive and negative. Could it be any side effects? It's omega-3 has been suspected for cardiac atrial fibrillation. So as a safety and also as explorative, we're gonna look at our data. But it's not a new study in itself, but we're gonna exploit the data as much as we can to explore and build new hypotheses. So
yeah, thank you.
So sorry, I have to ask one last clinical question again, because Adrian suggested to go for 400 units per day of vitamin D, particularly in nephrology. We have this issue with pill counts because our patients are taking so many medication each day. Would you have any objection to go with 20,000 units, say, each fortnight or each week? Or would you really recommend us to give the vitamin D on a daily basis?
So this is a really hot question in vitamin D research. And I think that the evidence is really pointing towards daily being best. I think if you give monthly, that's really not good. And the likely reason for this is that essentially what you get is a very unphysiological wave of 25-hydroxy-D, which then can cause inappropriate upregulation of vitamin D catabolism and can actually end up paradoxically rendering someone deficient. So I think you do get the best results with daily dosing. And I know people say you can give it weekly or 2 weekly because the half-life of 25-hydroxy-D is 4 weeks. I think you'll have to remember also the half-life of the parent cholecalciferol is just 12 hours. And 25-hydroxy-D is not the only metabolite in town. So if you want to, basically what we should be trying to do is replicate living in our ancestral state in equatorial Africa, getting sunshine every day, getting a steady state, and giving it daily is the best for that, despite the pill burden.
Thanks so much. So it was really fascinating to meet the two of you. Thanks so much, particularly for doing this study, because we are aware how difficult it has been in the last 2 years or so to conduct and to report clinical trials. And I think it's so important really for our patients that we have good evidence to base our recommendations upon. We're looking forward to hearing more from you, to reading novel vitamin D trials. But so long, thanks so much. Have a nice evening in London and in Oslo. Thank you.
Thank you.
Thanks.